Welcome to this video entitled Asthma. On day 1, Miss SN, a 24-year-old beauty therapist, was brought in at 11 a.m. by ambulance from her place of work. On admission, she was severely short of breath, drowsy, and unable to speak more than a couple of words at a time. Miss SN had been complaining of flu-like symptoms and a worsening cough for the past few days. That morning she had started to complain of increasing difficulty in breathing. She had been seen to use her inhalers several times, and had started to panic and then collapsed. The paramedic diagnosed an asthma attack and administered a 2.5 mg dose of salbutamol via a nebulizer, with some improvement in shortness of breath, and 35% oxygen via a face mask. Miss SN was able to confirm that she had a past medical history of asthma. On examination, she was tachypneic, respiratory rate of 28 breaths per minute, and tachycardic 140 beats per minute. Her blood pressure was 150 systolic, 95 diastolic with no paradoxus. On auscultation, her chest was almost silent. Her peak expiratory flow, abbreviated as PEF, was unrecordable. Chest X-ray showed no areas of consolidation and excluded a diagnosis of pneumothorax. After 15 minutes of 35% oxygen in the ambulance, her oxygen saturation, abbreviated as SpO2, was 85% and her arterial blood gases were as follows: PaO2 6.7 kilopascals. The reference range is 10.0 to 13.3 kilopascals. pH 7.47. The reference range is 7.35 to 7.45. PaCO2 3.7 kilopascals. The reference range is 4.67 to 6.0 kilopascals. Bicarbonate 22 millimoles per liter. The reference range is 22 to 26 millimoles per liter. Neurological observations were normal, as was her temperature, that is, 36.6 degrees Celsius. Her white cell count was 6.5 times 10 power 9 per liter. The reference range is 4 to 10 times 10 power 9 per liter. Miss SN was immediately given 60% oxygen via a high-flow mask and an intravenous sodium chloride 0.9% drip was started. She was moved to an acute medical ward and the following drugs were prescribed: IV hydrocortisone 200 mg immediately, then 100 mg 6 hourly. IV co-amoxiclav 1200 mg 3 times daily. Salbutamol 5 mg nebulized 6 times a day with 6 liters oxygen per minute. IV aminophylline 250 mg immediately followed by 1 gram in 1 liter sodium chloride 0.9% to run over 24 hours. Ipratropium 500 micrograms nebulized 4 times a day, with 6 liters oxygen per minute. Question 1 reads, what important signs and symptoms of a life-threatening exacerbation of asthma does Miss SN exhibit? An unrecordable peak expiratory flow, abbreviated as PEF, a near-silent chest and severe hypoxia despite 35% oxygen therapy. The British Thoracic Society, Scottish Intercollegiate Guidelines Network, BTS sign, Guidance on the Management of Asthma aims to alert doctors to the importance of recognizing the key features of the condition and to respond appropriately with optimum treatment. These guidelines are summarized in the latest British National Formulary, BNF. Many, if not most, hospital admissions for acute severe asthma are preventable, as are most asthma deaths. 1381 reported in 2004 in the UK. The severity of an asthma attack is often underestimated by the patient, their relatives and/or the doctors, largely because of failure to make objective measurements. In many cases, the patient will have been deteriorating over the preceding few days. This is typically seen as a reduction in peak expiratory flow measurement, an increase in diurnal variation of the peak expiratory flow, particularly morning, dipping, and an increase in symptoms such as shortness of breath and cough. Miss SN exhibited all the features of acute severe asthma: peak expiratory flow less than 50% predicted, tachypnea, tachycardia and inability to complete sentences, but the presence of one or more additional factors leads to a diagnosis of a life-threatening attack. First, her peak expiratory flow was unrecordable. Patients often say they are too short of breath to perform a peak expiratory flow and then, when encouraged, produce a reasonable result. A peak expiratory flow should always be taken, even if it is unrecordable, as this is a valuable clinical indicator of attack severity. However, this should not delay urgent therapy. A silent chest indicates poor air entry into the lungs as a result of bronchoconstriction. Despite 35% oxygen therapy, Miss SN was hypoxic on admission, although she had not progressed to retaining CO2, which can result from exhaustion and failing respiratory effort. Instead, her PaCO2 was slightly low, denoting hyperventilation. Question 2 reads, outline a pharmaceutical care plan for Miss SN. The pharmaceutical care plan for Miss SN should include the following: A. Optimize initial medical management of her life-threatening exacerbation of asthma as outlined in the BTS sign guidelines, by advising the medical staff on the following. 1. Appropriate dosage regimen of nebulized bronchodilators. 2. Role and choice of antibiotics. 3. Appropriate dosage calculation and administration of IV aminophylline. 4. Therapeutic drug monitoring of aminophylline and appropriate dosage adjustment. 5. Prescribing and administration of other medications for the treatment of a life-threatening exacerbation of asthma. B. Advise the nursing staff on the following. 1. Administration of nebulized bronchodilators. 2. Administration of IV antibiotics. And 3. Administration of IV aminophylline. C. Monitor Miss SN's response to treatment, see answer 4. D. Monitor for signs of adverse drug reactions. E. Review and advise on maintenance therapy once Miss SN is over the acute exacerbation. F. Provide information and education to Miss SN on all aspects of asthma and her medication. 1. Use of preventer and reliever inhalers. 2. Inhaler technique. 3. Asthma action plans and use of peak expiratory flow meters. And 4. Lifestyle advice, such as allergen avoidance, coping with coughs, colds and hay fever. Question 3 reads, did the treatment received by Miss SN comply with current guidelines regarding the management of life-threatening asthma? Would you recommend any adjustments or alterations to her prescribed therapy? Miss SN's initial treatment partly complied with current recommendations. The current BTS sign guideline recommends appropriate prescriptions for life-threatening asthma. Miss SN's therapy should be compared with them. A. Oxygen. Death as a consequence of an asthma exacerbation is most commonly due to hypoxemia and should be rapidly corrected. High concentrations of oxygen, usually 40 to 60% using a high-flow mask, should be administered, as there is little danger of causing hypercapnia, which might occur in chronic obstructive pulmonary disease. The nebulizer should also be driven by oxygen, rather than air. If arterial blood gases had revealed hypercapnia, this would indicate the development of near-fatal asthma and the need for emergency intervention and consideration for ICU admission. Miss SN remained hypoxic despite 35% oxygen in the ambulance, so it was vital that a higher percentage was administered on admission. The 60% oxygen started in accident and emergency department was appropriate. Oxygen saturations above 94 to 98% should be aimed for. B. Beta-2 agonist bronchodilators should be administered immediately in high doses, e.g. nebulized salbutamol 5 mg or terbutaline 10 mg, and repeated 4 to 6 hourly. The aim is to rapidly relieve bronchospasm. In mild to moderate exacerbations of asthma, there is no difference in efficacy between repeated administration of inhaled beta-2 agonist via a metered-dose inhaler with a large volume spacer compared to nebulized administration. However, if there are life-threatening features, nebulized administration should be used and IV beta-2 agonists should be reserved for patients in whom inhaled therapy cannot be reliably used, such as when patients are coughing excessively. Patients with severe asthma, that is peak expiratory flow or forced expiratory volume in 1 SWE cond, abbreviated as FEV1, less than 50% best or predicted, who have responded poorly to an initial bolus dose of beta-2 agonist should be considered for continuous nebulization. However, there is no evidence that this is likely to be more effective in relieving acute asthma. C. Corticosteroids should be administered in adequate doses for all patients with acute asthma because they reduce mortality, relapse rates, subsequent hospital admissions and the requirement for beta-2 agonist therapy. The earlier they are given in an acute attack, the better the outcome. There is no difference in efficacy between oral and parenteral steroid treatment, so steroid tablets should be used in all patients who are able to swallow and retain them and have no problems with absorption. Prednisolone 40 to 50 mg daily or hydrocortisone 100 mg every 6 hours should be prescribed for at least 5 days, or until recovery. The dose does not need to be tapered unless the patient has been taking steroids for more than 3 weeks or has been taking a maintenance dose of steroids. IV hydrocortisone may be appropriate initially if Miss SN is so breathless that she has difficulty swallowing, but this should be switched to oral prednisolone as soon as possible. There is no benefit in adding high doses of inhaled corticosteroids, abbreviated as ICSS, to the systemic steroid prescription, although any usual ICS therapy should be continued or restarted as soon as possible to ensure that the long-term asthma management plan is adhered to. D. Ipratropium bromide is not as effective as beta-2 agonists as an initial bronchodilator and may not be beneficial in mild exacerbations of asthma. However, it should be prescribed in combination with beta-2 agonists in patients with acute severe or life-threatening asthma, or those with a poor initial response to beta-2 agonist therapy, as greater bronchodilation may be achieved than with a beta-2 agonist alone. E. IV magnesium sulfate, dosed at 1.2 to 2 grams over 20 minutes, has been shown in a placebo-controlled trial to produce significant improvements in mean forced expiratory volume in 1 second in patients with severe asthma exacerbations, but not in those with mild exacerbations, although it does not affect airway hyperresponsiveness. IV magnesium should be given to patients with acute severe asthma with a poor initial response to inhaled bronchodilator therapy, and to those with life-threatening or near-fatal asthma. Miss SN should therefore be prescribed IV magnesium. F. IV aminophylline is unlikely to provide any additional bronchodilation compared to treatment with inhaled bronchodilators and steroids, and has many undesirable adverse effects. However, some patients with life-threatening or near-fatal asthma may gain some additional benefit, so it may be justified for Miss SN. However, the dose prescribed is not appropriate. Unless the patient takes maintenance oral therapy, a 5 mg per kilogram loading dose given over 20 minutes should be prescribed. This ensures that a steady-state concentration of theophylline is achieved rapidly. The loading dose should be followed by a continuous infusion of 500 to 700 micrograms per kilogram per hour, adjusted according to daily serum theophylline levels. It is therefore important that Miss SN's weight is known, or at least estimated with a high degree of confidence, to ensure that an appropriate dose is prescribed. G. Antibiotics are not routinely indicated for acute asthma because infections that precipitate an acute attack are likely to be viral. Miss SN is apyrexial, has a normal white cell count, and has no signs of consolidation on the chest X-ray. Therefore, the prescription of co-amoxiclav is inappropriate and should be challenged. Question 4 reads, which parameters would you want to monitor during the acute phase of Miss SN's asthma attack? A. Peak expiratory flow before and after nebulized or inhaled beta-2 agonist therapy, at least 4 times a day, throughout her hospital stay. B. Arterial blood gases. These should be repeated within 30 to 60 minutes of starting treatment, as the initial PaO2 is less than 8 kPa, and again if not improved 4 to 6 hours later. C. Oxygen saturation by oximetry to maintain SpO2 greater than 94 to 98%. D. Blood theophylline level, aiming for a concentration of 10 to 20 mg per liter. The level can be measured 6 hours after the loading dose to ensure it is not toxic, then daily thereafter to ensure therapeutic efficacy and absence of toxicity. E. Blood potassium level. Steroids, beta-2 agonists and aminophylline therapy can all cause hyperkalemia. F. Blood glucose level. This may be elevated by corticosteroids in susceptible individuals. G. Pulse and respiratory rate. The patient's mother arrived on the ward and was able to expand on Miss SN's past medical history and the events that had resulted in her being admitted to hospital. The family had a history of atopy, with Miss SN's father and brother both having asthma. Miss SN had been well until the last few days, when she had complained of feeling fluey, and had suffered from a barking cough, especially during the night. She also sometimes found it difficult to catch her breath, especially after exercise. She had bought some cough medicine which had no real effect, and so had seen her general practitioner who had prescribed a green inhaler. She commented that Miss SN had previously been given a brown inhaler by her general practitioner, which she had refused to take as she had heard that steroids can cause weight gain and thinning of bones and skin. Question 5 reads, was it appropriate for Miss SN's general practitioner to prescribe a salmeterol inhaler? The correct response is, no. It is not appropriate to prescribe a long-acting beta-2 agonist, abbreviated as LABA, such as salmeterol without also prescribing an inhaled steroid. A large multi-center study compared the safety of salmeterol to usual care in 26,355 asthma patients who had not previously received salmeterol. The study was terminated early when an interim analysis revealed a small but statistically significant increased risk of respiratory-related and asthma-related deaths in patients who had been treated with salmeterol compared to those who had been treated with placebo. The Commission on Human Medicines (CHM) advised that LABA should a. be added only if regular use of standard-dose inhaled corticosteroids has failed to control asthma adequately. B. Not be initiated in patients with rapidly deteriorating asthma. C. Be introduced at a low dose and the effect properly monitored before considering a dose increase. D. Be discontinued in the absence of benefit. E. Be reviewed as clinically appropriate. Stepping down therapy should be considered when good long-term asthma control has been achieved. Miss SN was starting to show signs of uncontrolled asthma, with recent onset of nighttime symptoms and worsening of daytime symptoms. Such patients are at significant risk of developing acute severe asthma. According to the BTS sign guidelines, Miss SN had previously been managed at Step 1, i.e. occasional use of relief bronchodilators. As her control had begun to deteriorate, her general practitioner should have stepped up her treatment, and the logical action would have been to add an inhaled steroid, Step 2. The current guidelines recommend a starting dose of 400 micrograms daily of beclomethasone given via a metered dose inhaler or equivalent in adults with mild to moderate asthma. It is possible that the general practitioner's decision to prescribe salmeterol had been influenced by the fact that Miss SN had previously refused to use an inhaled corticosteroid because of her perception of weight gain and thinning of bones and skin with these medicines. It would have been more appropriate to allay her fears through education about the low risk of systemic adverse effects from inhaled corticosteroid and the benefits of treatment. It is clear that this has not happened, and that she failed to understand that her asthma was deteriorating. Her general practitioner should perhaps have also initiated regular peak expiratory flow monitoring, and a short course of oral steroids might have been valuable in preventing this acute episode. By 8 p.m. Miss SN was feeling better and was able to give a history. She could remember feeling very short of breath that morning, and using both her salmeterol inhaler and her salbutamol inhaler several times with no effect. She said that she had been using her salbutamol inhaler at least 10 times a day in the last week or so. Her peak expiratory flow was now 140 liters per minute. Miss SN had never monitored her peak expiratory flow at home. Her oxygen saturation was 92% and her arterial blood gases were now Pa. O2 10.7 kPa. The reference range is 10.0 to 13.3 kPa. pH 7.44. The reference range is 7.35 to 7.45 Pa. CO2 4.7 kPa. The reference range is 4.67 to 6.0 kPa. Bicarbonate 23 millimoles per liter. The reference range is 22 to 26 millimoles per liter. Question 6 reads, was Miss SN correct to administer several doses of her inhalers as her attack worsened? The correct response is yes, but only of her salbutamol inhaler. The BTS sign guidelines recommend the administration of 4 to 10 puffs, given one at a time, of a short-acting beta-2 agonist metered dose inhaler via a large volume spacer, using tidal breathing repeated at intervals of 10 to 20 minutes. The patient's response to this treatment should be monitored to determine the next appropriate course of action, such as prescribing a short course of prednisolone or admission to hospital for further treatment and observation. The use of repeated doses of salmeterol will not be helpful because there is no additional benefit achieved by increasing the dose above 50 micrograms twice daily, although adverse effects will be increased. It is clear that Miss SN did not recognize the severity of her condition and had not sought urgent medical attention. One of the elements of an asthma action plan, see answer 18, should address this issue. Question 7 reads, what is a peak expiratory flow, and what is its role in the management of an asthmatic patient? The peak expiratory flow is the highest flow achieved from a maximum forced expiratory maneuver started without hesitation from a position of maximal lung inflation. Changes in peak expiratory flow are an important indicator of an asthmatic patient's clinical status and as such are a key element of any asthma action plan. It is important that the patient is encouraged to produce the maximal force of expiration that she can manage, otherwise inaccurate values may be recorded. Peak expiratory flow monitoring can easily be undertaken by the patient at home using a peak expiratory flow meter, prescribable on FP10, and provides a useful self-assessment tool. Measurements should be undertaken twice a day, morning and evening, before inhaled therapy. The results should be recorded on a peak flow monitoring chart FP1010, available from nhsforms.co.uk, or a peak expiratory flow diary available from Asthma UK, which can then be reviewed by the doctor. Patients should be taught to recognize signs of deteriorating asthma, namely a sustained reduction in peak expiratory flow value and/or a 25% or greater diurnal variation between morning and evening values, with the lower reading occurring characteristically in the morning, also termed morning dipping. Such changes are often the first signs that a patient's asthma is becoming uncontrolled. Question 8 reads, can a normal peak expiratory flow be predicted for Miss SN? It is not possible to predict a normal peak expiratory flow for an asthmatic patient. The predicted normal peak expiratory flow for a non-asthmatic person is related to height, age and gender, and can be obtained from various predicted normal peak expiratory flow charts. However, an asthmatic patient of the same height, age and gender may have a best peak expiratory flow considerably lower than the values in the chart. It is therefore important for asthmatic patients to establish their own record of monitoring so that comparisons to their own best recording can be made. In the newly diagnosed asthmatic, the predicted normal peak expiratory flow can be used as a level to aim for. For a known asthmatic, predicted peak expiratory flow should only be used if the recent best within 2 years is unknown. On day 2, the junior doctor decided to restart a beclometasone inhaler. Her pre-nebulizer peak expiratory flow was 120 liters per minute, compared to 220 liters per minute 15 minutes after her 6 a.m. nebulized therapy. It was therefore decided to continue ipratropium and aminophylline for at least another 12 hours. Following continuous administration of 60% oxygen, her oxygen saturation was now 98%, so the oxygen prescription was changed to, when required. Miss SN was now on the following: IV hydrocortisone 100 mg 6 hourly. Beclometasone QVAR, metered dose inhaler 50 micrograms per puff, 2 puffs twice a day. Salbutamol 5 mg nebulized 6 times a day using a compressor. Ipratropium 500 micrograms nebulized 4 times a day using a compressor. IV aminophylline 1 gram over 24 hours. And 60% oxygen when required. Her theophylline level was reported as 23 mg per liter. The reference range is 10 to 20 mg per liter. Question 9 reads, what alterations would you recommend be made to Miss SN's acute therapy now? The recommended alterations to Miss SN's acute therapy now include the following. A. Change her steroid therapy from the IV to the oral route. B. Adjust the dose of IV aminophylline to bring it into the therapeutic range and thus avoid the development of symptoms of toxicity. Miss SN is now much improved after 24 hours in hospital. She no longer needs to be given IV steroids and should be converted to a once-daily dose of oral prednisolone, dosed at 40 to 50 mg, in the morning. In fact, this change could have taken place the previous evening. Miss S.'s plasma theophylline level is slightly high, although she is not showing any symptoms of theophylline toxicity. Theophylline exhibits first-order pharmacokinetics, so it is possible to calculate a dose to bring the theophylline level into the therapeutic range using the formula S multiplied by F multiplied by the dose divided by T is equal to CSS multiplied by Cl, where S is the salt factor, that is 0.79 for aminophylline. Dose refers to the dose in mg, F refers to the bioavailability factor, T refers to the dosage interval in hours, CSS refers to the average plasma concentration at steady state, and Cl refers to the clearance. In this case, F is a constant with a value of 1, because the drug is being given IV, therefore 0.79 multiplied by 1 multiplied by 1000 mg divided by 24 is equal to 23 mg per liter multiplied by Cl, thus Cl is equal to 1.43 liters per hour, for this patient. To give an average theophylline concentration of 15 mg per liter, then 0.79 multiplied by 1 multiplied by dose divided by 24 is equal to 15 multiplied by 1.43. Thus the dose is equal to 652 mg per 24 hours. This could be rounded down to 650 mg for ease of administration. Alternatively, it should be realized that as S, F, T, and Cl are all constant, the above formula can be rearranged to dose divided by CSS is equal to Cl multiplied by T divided by S multiplied by F. Therefore, the calculation for the new infusion rate can be simplified to dose 1 divided by CSS1 is equal to dose 2 divided by CSS2, where dose 1 and CSS1 refer to the current infusion rate and serum theophylline level, and dose 2 and CSS2 refer to the required infusion rate and target serum theophylline level. Therefore, dose 2 is equal to dose 1 multiplied by CSS2 divided by CSS1, which is equal to 1000 multiplied by 15 divided by 23, which is equal to 652 mg per 24 hours. The need for continued nebulized ipratropium and IV aminophylline should also be reviewed, as these two drugs can often be discontinued once the patient has recovered significantly from the acute event. Question 10 reads, is the initial choice of beclometasone inhaler more appropriate than other inhaled corticosteroids for Miss SN? To date, no significant clinical advantages between different inhaled corticosteroid have been demonstrated. The choice of inhaled corticosteroid needs to be made on an individual patient basis, taking into consideration the choice of inhaler device and cost. Meta-analysis of inhaled corticosteroid use has shown that beclometasone is dose equivalent to fluticasone and mometasone, but requires half the dose of budesonide and chlorofluorocarbon, abbreviated as CFC, beclometasone, to provide equal clinical activity. The difference between beclometasone and CFC beclometasone is due to the delivery of smaller particles, which improves lung deposition. This is not true for all non-CFC beclometasone products. Some meta-analyses have demonstrated small improvements in forced expiratory volume in 1 second and morning peak expiratory flow with fluticasone, but the clinical significance of this is not clear. The 2008 NICE appraisal concluded that when comparing inhaled corticosteroid at equivalent low or high doses, there was no difference between them in terms of effectiveness. It is appropriate to start Miss SN on cuvarbeclometasone as a first-line inhaled corticosteroid at Step 2 of the BTS-SIGN guidelines, provided she can use the device effectively. Question 11 reads, how can the pharmacist contribute to optimizing the administration of inhaled therapy? The pharmacist can have a key role in the selection of the most appropriate inhaler device for each individual patient and in counseling on its correct use. Many studies have shown that inhaler technique is frequently poor, even after verbal instruction and demonstration. Patients with asthma should only be prescribed inhalers after they have received training and education on how to use them and have demonstrated satisfactory technique, as this will ensure that they obtain maximum benefit from therapy. Inhaler counseling requires patience and tact, and the patient's beliefs and opinions should be respected when deciding on the appropriate device to prescribe. In order to obtain the maximum benefit from different inhaler devices, it is important to ensure that each patient can achieve the optimum inspiratory flow rate for their inhaler. This can be determined using an in-check dial inspiratory flow meter, Clement Clark Limited, Harlow, UK, which mimics the internal resistance of a range of inhaler devices, allowing the measurement of inspiratory flow rate and ensuring the patient can inhale through a device at its optimal inspiratory flow rate. Optimum inspiratory flow rates for common devices are A. Metered dose inhalers 25 to 90 liters per minute. B. Turbohalers 60 to 90 liters per minute. C. Accuhalers 30 to 90 liters per minute. A frequent error made by 26 to 70% of patients using metered dose inhalers is failure to inhale slowly and deeply. Increasing inspiratory flow rate from 37 to 151 liters per minute using a metered dose inhaler reduces total lung deposition from 11.2% to 7.2%. Conversely, reducing the inspiratory flow rate through a turbohaler from 60 to 30 liters per minute will reduce lung deposition by 50%. Inhaler technique is not solely dependent on inspiratory flow. Use of a metered dose inhaler requires the patient to remember to shake the canister, and to have good coordination and dexterity to ensure that actuation, inhalation and breath holding occur in the correct sequence. Patients with poor coordination, or who are unable to hold their breath, or who cough while using their metered dose inhaler, the cold freon effect caused by the impact of the cold propellant on the back of their throat, should use a large volume spacer. This can increase lung deposition, reduce coughing and overcome problems with breath holding by acting as a holding chamber for the aerosol. This allows the patient to inhale their medication over several breaths, which also makes coordination less of an issue. However, spaces can be large and cumbersome and make the patient feel conspicuous, and so they may not use them. Dry powder devices are often easier to use and frequently preferred by patients, although they are generally more expensive than metered dose inhalers and require the patient to hold their breath. Other devices that can be used to assist inhaler technique training include the two-tone trainer, Cande Medical Limited, Turbohaler trainer whistles, AstraZeneca, the MagFlow inhaler trainer, Fine Dynamics, or the aerosol inhalation monitor, AIM machine, Vitalagraph Limited. When inhaled corticosteroids are inhaled, it is important that the patient is advised to rinse their mouth with water to prevent local adverse effects such as oral candidiasis. The use of the metered dose inhaler with a large volume spacer will also reduce oropharyngeal deposition, which further reduces the risk of oral candidiasis, particularly when large doses are required. Question 12 reads, how would you address Miss SN's concerns about the risks of inhaled corticosteroids so that she can make a more informed decision about taking her preventer therapy? It is important to discuss with Ms. SN the benefits of inhaled corticosteroid against the potential risks. There is little evidence that doses below 800 micrograms, CFC beclometasone or equivalent, per day cause any short-term detrimental effects apart from dysphonia and oral candidiasis, side effects that can be minimized by following the advice in Answer 11. The possibility of long-term side effects from inhaled corticosteroid is still unknown. Higher doses of inhaled corticosteroid have been associated with a low but increased risk of systemic adverse effects such as adrenal suppression, that is less than 1 over 10,000, but the extent of such effects is poorly quantified. Systemic effects are much less likely with inhaled corticosteroid than with repeated doses of oral steroids for asthma exacerbations. The need for oral steroids should also be reduced by the use of inhaled corticosteroid as a preventer. To minimize risks, Ms. SN's inhaled corticosteroid should be titrated to the lowest dose that controls her asthma. Later that afternoon, the junior doctor rang to say that the IV aminophylline was being discontinued. He asked what oral dose he should prescribe. Question 13 reads, "What advice would you offer?" The correct response is, there is no indication to convert Ms. SN to oral theophylline at this stage. Oral theophylline should initially be considered in patients who need to move up to steps 4 to 5 of the BTS sign guidelines, i.e. when asthma is not adequately controlled on a combination of an inhaled corticosteroid, that is 800 micrograms daily of beclometasone CFC metered dose inhaler, and an additional drug, usually a long-acting beta-2 agonist. Occasionally oral theophylline may be prescribed at step 3 of the BTS sign guidelines if a patient's asthma is not adequately controlled on ICS, 800 micrograms daily, and has failed to respond at all to a long-acting beta-2 agonist. The junior doctor should be advised to reduce the aminophylline infusion rate slowly over the next few hours. On day 3, Ms. SN felt much better, almost back to her normal self. Her peak expiratory flow was coming up but still showed quite a difference between pre- and post-nebulizer therapy, that is 255 and 325 liters per minute, respectively. On the ward round, the new registrar asks how they should step up her therapy. Question 14 reads, "What are the roles of long-acting beta-2 agonists abbreviated as LABAs, leukotriene receptor antagonists and increasing doses of inhaled corticosteroids in the treatment of asthma?" LABAs, e.g. salmeterol, formoterol, are synthetic sympathomimetic bronchodilators. They are structurally and pharmacologically similar to the short-acting beta-2 agonist salbutamol and are licensed for the treatment of reversible airway obstruction in patients with asthma who are inadequately controlled on inhaled corticosteroids. Leukotriene antagonists montelukast or zafirlukast selectively block the action of leukotrienes on the respiratory tract, resulting in an anti-inflammatory and a bronchodilator action. Evidence supports their use as potential add-on agents in asthma uncontrolled by inhaled steroids. LABAs have a prolonged duration of action of 12 hours, compared to 4 to 6 hours for salbutamol. A meta-analysis demonstrated that the addition of a LABA to a low-dose inhaled corticosteroid reduced the risk of exacerbations by 19%, improved lung function, increased the number of symptom-free days and reduced the requirement for rescue short-acting beta-2 agonist therapy. The addition of a LABA achieves a similar reduction in the risk of exacerbations as increasing the inhaled corticosteroid dose, but results in a greater improvement in lung function, an increased number of symptom-free days, and a reduced requirement for rescue short-acting beta-2 agonist therapy. As discussed earlier, LABAs are not a replacement for inhaled steroids, and nor should they be used for the relief of acute attacks. An important counseling point to discuss with patients receiving LABAs is the differences between these and salbutamol. Leukotriene receptor antagonists are more effective than placebo, but should be prescribed in combination with an inhaled corticosteroid. A meta-analysis comparing leukotriene receptor antagonists with inhaled corticosteroids demonstrated that patients taking the former were 65% more likely to experience asthma exacerbations, although a similar benefit on improved lung function, symptoms and reduced rescue medication use was observed. The addition of leukotriene receptor antagonists to inhaled corticosteroids produces modest improvements in lung function. However, LABAs produce greater benefit and have a 17% lower risk of exacerbation than leukotriene receptor antagonists. In aspirin-allergic asthmatics, improvements in pulmonary function and symptoms may be achieved when montelukast is added to inhaled steroids. Leukotriene receptor antagonists used in combination with intranasal corticosteroids may also be effective for symptomatic relief of seasonal allergic rhinitis. In summary, asthmatic patients who are inadequately controlled on low-dose inhaled corticosteroids should also be prescribed a LABA, Step 3 of the BTS sign guidelines. If asthma control remains suboptimal, the inhaled steroid dose should then be increased before treating at Step 4. If there is no response to the LABA, it should be stopped and the inhaled steroid dose increased. Consideration can also be given to adding in a leukotriene receptor antagonist. Question 15 reads, what would you recommend be prescribed for Miss SN? There is unlikely to be a definite correct answer to this question. A combination of inhaled corticosteroid and LABA may well be appropriate. Prior to the onset of Miss SN's symptoms of deteriorating asthma control, she was prescribed only a salbutamol inhaler at Step 1 of the BTS sign guidelines. Therefore, it could be argued that she has not yet been treated with an inhaled corticosteroid and so should continue on QVAR, Step 2 of the BTS sign guidelines, and her symptom control and treatment reviewed in the outpatient clinic after discharge. However, it is important to prescribe treatment that is appropriate to the severity of a patient's asthma symptoms, with the aim of achieving early control before stepping down when control is good. Consequently, it may be more appropriate to prescribe treatment for Miss SN at Step 3 of the BTS sign guidelines, and step down if control is achieved and sustained over a few months. Using this rationale, Miss SN should be prescribed a combination inhaler containing an inhaled corticosteroid and a LABA. The choice of which of the available products to prescribe, e.g. Seretide, Fostair or Symbicort, will depend on her ability to use the device, her preference and the cost. There is little evidence to support the addition of a leukotriene receptor antagonist at this stage. Approximately 3 months is an appropriate period to review the control of her asthma, preferably by using peak expiratory flow and symptom diaries, before considering whether to step down her treatment. Polypharmacy should be avoided wherever possible, as it may adversely affect adherence. On day 5, Miss SN's peak expiratory flow continued to improve and stabilized around 460 liters per minute. She felt completely back to normal and was eager to go home. On the ward round, there was discussion as to whether a Symbicort maintenance and reliever regimen, also called Symbicort Smart, would be appropriate for Miss SN. Question 16 reads, is it appropriate that Miss SN be allowed home now? The correct response is no. Patients should not usually be discharged from hospital until their symptoms have cleared and their peak expiratory flow has stabilized. A guide to this is when the peak expiratory flow is greater than 75% of the predicted or best value. Diurnal variability is less than 25% and there are no nocturnal symptoms. Patients should also be on the medical therapy they will continue at home. As Miss SN has obviously improved, it would be appropriate to discuss changing her nebulized therapy back to standard inhaler devices at this time. Question 17 reads, would you recommend Symbicort maintenance and reliever therapy, also known as Symbicort Smart, as a suitable option for Miss SN? Possibly not at this stage. The basis for prescribing Symbicort maintenance and reliever therapy, also called Symbicort Smart, relies on the fact that formoterol has an onset of action, that is within 3 to 5 minutes, that is comparable to that of salbutamol and, unlike salmeterol with an onset of action of 15 to 30 minutes, can thus be used as a reliever medicine. A comparison of fixed-dose seretide plus salbutamol as needed versus Symbicort Smart 200/6, 1 or 2 inhalations twice daily plus 1 inhalation as needed, in 2,143 asthmatic patients demonstrated that Symbicort Smart significantly reduced the annual exacerbation rate compared to regular seretide use. Despite the fact that patients can use additional doses of their Symbicort as needed, the mean equivalent inhaled corticosteroid dose was not significantly different between the two groups, and there was less need for rescue medication in the Symbicort Smart group. Consequently, Symbicort Smart is a cost-effective treatment regimen. However, it is important that patients who are prescribed Symbicort Smart are carefully selected and receive clear education. There are several groups of patients for whom this treatment regimen may be inappropriate. For example, those who may be poorly adherent to their medication, particularly if they worry about side effects from their inhaled corticosteroids. Patients who are unable to monitor their asthma control adequately are unlikely to be able to adjust the dose of their Symbicort independently, and patients who overuse their short-acting beta-2 agonist because of poor perception of their symptoms should not use this regimen. Symbicort Smart may be inappropriate for Miss SN because she has previously been poorly adherent with her prescribed asthma treatment and has been reluctant to use her inhaled corticosteroid. On day 6, Miss SN was allowed home after being back on her inhaled bronchodilator therapy for 24 hours. An asthma action plan was discussed with her before she left. Her discharge prescription was salbutamol metered dose inhaler 100 micrograms per puff, 2 puffs 4 times daily and when required. Prednisolone 40 mg each morning for 5 more days, then stop. Seretide 125 metered dose inhaler, 2 puffs twice daily via spacer. Peak flow meter and chart. Question 18 reads, what are the key elements of an asthma action plan? The key elements to an asthma action plan are A. Instructions on how to recognize symptoms of good, worse and severe asthma. B. Instructions on when to use a reliever inhaler, e.g. short-acting beta-2 agonist, and, if necessary, when to increase the dose of the preventer inhaler, e.g. inhaled corticosteroid, as symptom control starts to worsen. C. Instructions on the prompt use of a reliever inhaler and when to take a course of oral corticosteroids at the onset of severe symptoms. D. Instructions on how to monitor response to treatment. E. Information on when to seek assistance or follow-up review to assess asthma control. And F. Useful contact numbers, e.g. doctor or nurse. All patients admitted to hospital with an exacerbation of their asthma should be offered a written, personalized asthma action plan. Asthma action plans have been shown to reduce hospital admissions, emergency room visits, days off work or school, nocturnal asthma symptoms, and to improve quality of life. There is no consensus about the exact components of an asthma action plan, although the key elements above are frequently suggested. It is important for the plan to be discussed with, and individualized for, each patient. The patient should be advised of the aims of asthma treatment in terms of symptom control and the best peak flow readings. Patients should check and record their peak flow regularly, as this helps to give an objective measure of asthma control, and the severity of an exacerbation can then be determined by expressing their peak flow as a percentage of their best value. Action plans need to instruct patients on the action to take following worsening symptoms, or when their peak flow has dropped below a pre-specified value. A final important component of an action plan is to advise the patient to seek urgent medical attention when treatment is not working. A number of generic asthma action plans are available, e.g., Be in Control, Asthma UK. Question 19 reads, how would you counsel Miss SN on her discharge medication? Miss SN should by now have received extensive counseling from the multidisciplinary team, including the pharmacist, caring for her in the hospital. There are, however, some specific points related to her medication that should be discussed at discharge. It should be emphasized that Miss SN is being asked to use her reliever, that is salbutamol, regularly 4 times a day and also when required for an initial short period of time following discharge. This regular use of her reliever should be reviewed after a suitable period. If Miss SN responds well to the Seretide inhaler, she may only need to use her reliever intermittently and prophylactically, e.g. before exercise. It should be explained that the spacer used with Miss SN's Seretide, which is a preventer, may be used with the salbutamol reliever during an acute exacerbation in conjunction with her asthma action plan, see answer 18. However, it should be stressed that this is not a substitute for seeking urgent medical attention. The need to complete the course of oral steroids should be emphasized. Prednisolone should be taken for 5 days or until recovery. Therefore it is reasonable for Miss SN to be discharged with a short course. This treatment should be explained in light of the co-prescription of inhaled steroids. Any worries regarding the safety or adverse effects from short courses of oral steroids should be addressed. The importance of regular use, that is twice a day, of her preventer Seretide inhaler should be reiterated. It should be checked that Miss SN knows how to use the peak expiratory flow meter and chart. Question 20 reads, how should Miss SN's pharmaceutical care be continued over the next few months? By ensuring good communication between secondary and primary health carers, continual assessment of her condition, and by reinforcing education as necessary. Good communication with Miss SN's general practitioner is essential. Information supplied to her general practitioner should include peak expiratory flows on admission and discharge, details of medication changes and treatment to be continued at home, plus a copy of any asthma action plan discussed in the hospital. All patients should be followed up in a hospital clinic within 1 month of discharge, in addition to follow-up by the general practitioner or asthma nurse within 2 working days. Community and hospital outpatient pharmacists are in an ideal position to offer reinforcement of education to patients such as Miss SN when they return for repeat inhaler prescriptions. Miss SN is currently being managed according to Step 3 of the BTS SIGN guidelines, but continual assessment of her asthma control is essential, not only to ensure stepping up of treatment if necessary, but also to review stepping down when possible. The BTS sign guidelines emphasize the importance of considering stepping down treatment in well-controlled patients to ensure that they are not inappropriately over-treated. In particular, patients should be maintained on the lowest possible dose of corticosteroid. A reduction in dose should be considered every 3 months, reducing the dose by approximately 25 to 50% each time.
Thank you.